Welcome, everyone, and thank you for joining us for today's webinar on using effective risk communication to increase vaccination rates. My name is Ian Culbert. I am the Executive Director of the Canadian Public Health Association, and I will be your host this afternoon. I would like to begin by acknowledging that while we are all coming from different parts of Turtle Island, CPHA's offices are located on the ancestral and unceded territory of the Algonquin and Anishinaabe peoples. I'm also very grateful today for the support from GlaxoSmithKline, GSK, who are the supporters of today's webinar as a part of their sponsorship of CPHA's annual conference last year. So thank you to GSK for their support. So without further ado, I'm going to introduce our speakers in the order which they'll be speaking to you this afternoon. First is Anton Holland. He is the president and CEO of NIVA Inc., a science, communication, and knowledge mobilization firm based in Ottawa. Anton has over 30 years of experience as a researcher, science writer, knowledge broker, and communication strategist, working with federal, provincial, and municipal health authorities, as well as NGOs and industry. Following Anton will be Kelly Grindrod. And Kelly is an associate professor at the University of Waterloo and the pharmacy lead for the region of Waterloo Vaccine Task Force. She is the lead and founder for Pharmacy 5 and 5, which is a popular pharmacy learning platform that develops multimedia tools to provide information and education about medications and vaccinations. Over the pandemic, she has co-developed several patient and clinician resources to combat misinformation and support patient decision-making about vaccines. So today's session is being recorded and will be available on CPHA's YouTube channel after the session, and all registrants will receive a link to that recording once it becomes available. So without further ado, I'll turn the floor over to Anton.
Thank you, Ian. So as the description of this webinar noted, it was pretty clear from the outset of the COVID-19 crisis that one of the main victims of the situation would be clarity, credible, consistent, and understandable information that kind of needed to guide the actions of citizens in the fight against COVID-19. The situation has constantly been changing throughout the pandemic. Information about how different populations are being affected, what we know about how the virus and its variants behave, the ways in which it affects different people, what we need to do to keep people safe as they go about their daily business. And this means that messages from experts have been continually revised too. What has made things even more complicated is that all of this information, both good and bad, has come at us from all angles, inundated our ability to process it. And none of this has been more apparent than when it comes to communicating about vaccines. What has been a real learning experience for many people is that science does not define a point in time. The science on any given issue, and this has been especially true during this pandemic, changes all the time. That's what science does, and that's how we find solutions to problems. At no time is there a static list of facts that allows us to communicate immutable guidance on how we should act. As the science evolves, the guidance evolves right along with it. The problem is there's a wide swath of the public who may want to trust scientists, but they just don't understand how science works. The information surrounding vaccines has been confusing, and sometimes messaging has appeared contradictory. The approaches that government bodies have taken in communicating that information have, frankly, not helped matters much. It's no wonder the average person is confused. And all of that sets up a perfect environment for misinformation and disinformation to take hold. One thing people have had to get used to is the idea of uncertainty. With respect to vaccines, it's the notion that while testing on the vaccines has occurred, there's still some uncertainty with respect to things like efficacy. How effective are the various versions of the vaccine at combating the different variants, as well as safety? There has been much conjecture over adverse effects and so on. So the issue is that most people have a difficult time dealing with uncertainty and the way it's presented. And even more still don't know how probabilities work. Most people are, in fact, generally receptive to science-based messages surrounding vaccines, but are confused because the processes behind how the vaccines are developed, tested, and monitored are a mystery to them. They've heard that science is about finding out the truth, but if science keeps changing, does that mean our foundations for truth are malleable as well? I only have 15 minutes, so I'm going to run through a number of the issues that have plagued science-based communication about vaccines during the pandemic, and I hope present some solutions. So for the rest of my talk today, I'm going to start by covering a few technical things, then I'm going to move on to some people things. The two need to be interlinked if we want to be successful in vaccine communication. One place to start is the delivery of plain language information about vaccines. Simply providing information in plain language won't necessarily get the right messages across effectively, but it's a place to start. There are portals that have been set up that attempt to provide a one-stop shop for this kind of information, but they have been difficult to search and navigate, and they just aren't user-friendly. Sites like the one set up by the Ontario government are supposed to provide information on the vaccines, but they still don't have a lot of organization. So the information might be there, but it's lost to the average user who has to really go hunting for it in an uncurated fashion. One key issue is that while new information is being posted as it becomes available, older information that might be in conflict with the newer material is often left up. In many cases, information put out there by provinces barely meets the minimum bar for plain language, nor does it actually address the issues for which it appears to be designed. On the other hand, provinces are often opting to link to information developed by third parties, like hospitals, which may do a better job of connecting with local audiences, which in turn engenders trust. There's a site put up by the federal government on COVID-19 vaccines and Indigenous peoples. At first glance, it seems like there's a lot of information up there, but doesn't actually tell me much that I need or want to know if I am an Indigenous person uncertain about vaccines. In some cases, the information put out on government sites may in fact be incorrect. In a fact sheet on vaccine myths and rumors put out by the Ontario government, the following is noted. No one is known to have died as a direct result of the COVID-19 vaccine. While deaths are very rare, this statement is not true, and as a result, it generates mistrust in all of the information published by government vaccine. And that's a petri dish where misinformation and disinformation can start to grow. A key issue with respect to providing information about vaccines is how we deal with all of the numbers, the number of people involved in clinical trials, the number of people experiencing adverse effects, the rate of effectiveness, ability to keep people out of hospital, and so on. The vast majority of people, when it comes to these things, are for all intents and purposes enumerate. I'm not talking about the basic arithmetic and math that's necessary to get basic tasks done every day for personal lives and business. But when it comes to really big numbers, probabilities, and what those things mean for personal decision-making, most people are at a loss. That doesn't stop people from being interested in this kind of information, looking up the latest charts and graphs, and quoting the perceived trends to friends and family. It's just that they don't know how to interpret that information, and in general, a pretty poor job has been done at helping the average person over that hurdle. Throughout the pandemic, we've been looking at numbers, graphs, and charts, trying to understand what is happening, predict what will happen, know how many people are getting vaccinated and what proportion of the population that is, and see how that is affecting infection rates. We're hungry for data that is finally telling us that everything is going to be fine and that we can finally open up some things. But the truth is, data are only facts and they're not a crystal ball, especially when we treat data poorly most of the time. There's been excessive use of absolute numbers rather than percentages. For example, there were 1,300 new cases in Ontario today. That tells us nothing. What's the trend? How rapidly is the number increasing or decreasing? Or is it just steady? What's causing those things to happen? Visual representation of data is effective, and interactivity where possible is an added bonus. It allows people to explore the data and get a visceral feel for it, making them more comfortable. What needs to be married with this is more descriptive information that allows the average person to understand what the data is showing them. Why do I care about the different scales being used? What's that telling me? These are some of the answers that the descriptive information should provide. In the daily press conferences, there's often been mention of uncertainty, and often this has been in reference to uncertainty in how and why things are changing, how the vaccines work against the different variants, and how this will affect the situation, or what measures we should be taking in order to protect ourselves and others. Listen to the scientists is a mantra that is often repeated. That's very good advice, but it comes with some issues. The main one being that we don't know how to talk to the average person about scientific uncertainty. As we've seen during a rapidly changing pandemic landscape, The system is complex. There are knowns and unknowns, and interactions that at any given point are unknowable until a situation plays out. As new information becomes available, it may temporarily yield unclear or conflicting ideas. All of this has made precise predictions, timelines, and results challenging at times. Yet exactly this type of information is necessary to allow people to make the right decisions about vaccines and what the consequences of those actions will be. The scientific uncertainty surrounding everything with respect to the pandemic, including, of course, the vaccines, has been extremely difficult to communicate to the public, and I suspect decision makers in government, but I haven't been privy to those internal discussions. The word uncertainty itself has different meanings when used in everyday speech versus a scientific context. So even attempts to be transparent by referencing that uncertainty can make the problem worse. In scientific discourse, uncertainty conveys the degree to which something is known. In everyday parlance, the word conveys the sense of not knowing. On the face of it, the difference may appear subtle, but when communicating health information to the public, the difference is important. How scientists express this uncertainty affects people's acceptance of the science, as well as their trust in the scientists and health officials who are reporting the results. Expressing uncertainty using a concrete range of possibilities increases trust, whereas uncertainty expressed with respect to unpredictable impacts can erode trust in scientists. This may be because public opinion is dependent on how the evidence is framed. We saw that with the advice being provided by NACI at one point, and which generated a lot of controversy. That, of course, is the National Advisory Council on Immunization. We were told at one point by people we trust that the best vaccine was the first one available to us. So we had the AstraZeneca jab, and we were proud of ourselves for doing so. Later, NACI, an organization that advises the people we trust for health information, released its own statement that implied that the mRNA vaccines were better than AZ. And that left a lot of people who had the AZ jab feeling like they had been taken for a ride and were inadequately covered. Trust destroyed. Time is short, so I want to provide some information on a way forward. Up until now, I've been talking about a bunch of technical aspects with respect to providing information that will hopefully counter vaccine hesitancy. But what about the people side of things? This brings us to the idea of dealing with people's mindsets. We all have a mindset. It's the thing that helps us make sense of what appear to be overwhelming ambiguities in our lives. It consists of our latent ideas about how things work. They are key to understanding the values of a decision-making process. But the good thing, and the bad thing, I guess, is that they are malleable depending on the context. We can use mindsets to examine potential behaviors and decisions and approach them accordingly. There have been two major categories that have been easily identifiable when it comes to vaccine hesitancy. There are people with a communal mindset. People who have this mindset think a lot about their physical health and that of their loved ones. That's what they value the most. But their confusion surrounding vaccine information may lead them to have staunch misgivings. And as a result, won't do something because someone else tells them to. To fill in their gaps in understanding, they want to do their own research. And then there's an individualistic mindset. This is a completely different version of reality to other people. People with this mindset focus more on risks than on benefits. They value their autonomy and see the pressure to get vaccinated as having a negative impact on that. They see pandemic interventions as having done more harm than good. This group isn't selfish. They will still help people. But unlike the communal mindset people, they don't see helping others as something that fundamentally defines them. It's a secondary benefit. People with this mindset feel that the government bungled things from the beginning. The virus should have been left to run its course. Populations should just achieve natural immunity. These two mindsets require different approaches to reduce vaccine hesitancy. For the communal mindset people, appeal to what matters most to them. Since they value everyone's health, the question to answer is, why is getting vaccinated an urgent matter? The sooner they get vaccinated, the sooner they can be with people they love. A common message for them is that there is a way out, and vaccination is it. Activity on social media is important for this group. You can see how the narrative is changing, and sometimes engaging the right personality strategically can have a wide reach and move the needle. For people with an individualistic mindset, appeal to their desire for freedom. Being vaccinated is their ticket to being able to govern their decisions about their own lives and get the government off their backs. When push comes to shove, this group of people will help others, especially if it's seen as a noble gesture. So if someone they know is at much greater risk from the virus, this could be an effective message for them as well. What won't work with this group of people is throwing more facts and evidence at them. Relying on logical arguments with this group will probably backfire, because by doing so, you make them feel like they're wrong for having certain fears, things that in many ways define their identity. As the media has mentioned so often, we've been drinking from a fire hose of information since the beginning of the pandemic. Advice has changed frequently and has been presented in a way that confuses people. When it comes to vaccines in particular, the messaging hasn't necessarily taken into account what actually drives the decision-making in those that are vaccine hesitant. We'll soon be faced with a new challenge. As vaccines become available for children, the work of getting shots into their arms will begin. Throughout the pandemic, parents have heard that COVID-19 cases among children are generally mild and rarely serious. Data coming out of Ontario schools show that less than 1% of school-aged children infected with COVID-19 end up in hospital. We've deprioritized children throughout our vaccine campaign in order to settle people's minds. The message is that schools are good and children are doing all right as well. Now, all of that has to be undone, and it has to be undone in a way that doesn't once again destroy trust. There's going to be a lot of hard work to manage this campaign. Answering parents' questions about vaccine safety will be the main key to success. Thanks.
That is great, Anton. Thanks so much for kicking us off with a load of information, and I'm sure there's tons of questions buzzing in my head, so I'm sure that's the same for our participants. So just a reminder that if you want to pose a question, just use the Q&A function at the bottom of your screen, and we will address your questions after Kelly has spoken. So without further ado, I will invite Kelly to share her screen and give the floor over to you once you unmute yourself, Kelly.
There we go. You can hear me okay, and you can see my slides?
Yes, we can. That's
okay.
Perfect. Thanks.
So, Anton, I could listen to you all day. Everything that you said is very much what we're thinking about in my world as well. So as was alluded to in my intro, I'm a pharmacist. I'm a practicing pharmacist. I'm also a vaccinator. So in the role that I've played in my own region, I help the pharmacies liaise with public health and with government, trying to kind of navigate the vaccine rollout in the pandemic. So I'm going to talk about 4 things here, and really it will align well with what Anton has just gone through. So risk communication from a pharmacist perspective, as someone who is on the ground talking with patients, how we communicate about change and conflict. Those aren't necessarily the same things, but they felt a lot like the same thing throughout the pandemic. Tips and my experiences in building useful tools and messages. And I'm going to end talking about the power of stories. So the thing that we felt a lot in the pandemic is enormous constant change. So it's change in science as science evolves and our understanding of science evolves, and then the policies that change with the science or that might be delayed. But regardless, this change is constant. And there are real challenges to constant change or just change and conflict in general. So there's a great paper that was published this summer in August, Nagler et al., the Annals of Behavioral Medicine 2021. One of the things that they looked at was something called a carryover effect. And so too much change or conflict can have this carryover effect. So what the carryover effect is when you're exposed to conflicting health information on any topic, it can lower future perceptions of unrelated health information topics. So for example, one way that we may have seen this play out in the pandemic is early conflict around masking. And as a healthcare provider who was called a lot early in the pandemic by friends and family, should I wear a mask? And we were so sure of ourselves, no, we only wear masks in hospital or healthcare. No, we don't need that. And then as the science evolved and there's this value now seen to be, potentially value in wearing masks, that started to become conflicting information. And what this research and research like it shows us is that the conflict that happened back then is quite possibly impacting us now. Similarly, information around the vaccines being safe and then having the AstraZeneca vaccine-induced thrombotic thrombocytopenia, or VIT, horrible clotting disorder. And as it evolved, it went from being just, oh, it's initial clots, but COVID causes clots, to realizing it was actually an extremely serious, rare, but extremely serious side effect. The conflict that happened around that could very well be impacting us future. So we're very much anticipating that will have an impact on kids' vaccinations and public perceptions of that. But then this research also tells us it could impact other future things, even unrelated to this. Confidence in messages around smoking cessation, sedentary behavior, diet, things like that. And so we're always having to manage how much conflict we create with the messages, and realizing it will keep impacting us into the future. Now, the public may not appreciate that change or conflict is a normal part of science. And one thing that we've really seen in this pandemic is that social media has amplified conflict, so that it may even interpret change as conflict, and provides a platform for conflict. So scientists have used social media probably very much to their own benefit to connect with people who have different perspectives and to kind of hash things out, sometimes collegially, not always collegially. And that actually can amplify that conflict, and as we see from research like this, potentially impact other unrelated health areas. So how do we communicate change in the pandemic? So what we've been doing is we've been communicating to the public and healthcare professionals at the same time, kind of flattening that hierarchy. And the advantage is that it's really sped up communication and implementation. A press conference can happen. Everybody watches it at the same time. Everybody finds out at the same time, and things are implemented almost immediately. But the disadvantage, and as a frontline healthcare provider, that we really experience is it moved the burden of explaining and translating onto accessible healthcare providers. And I'm going to give an example here in a second. But also this kind of constant change in messaging can also really amplify this real or perceived conflict between government, public health, advisory groups. NACI is one, but there's many others, associations, regulators, and scientists. So this was my experience in the pharmacy world. So as the pharmacy lead for our vaccine task force, I spent a lot of time talking to pharmacists in all different environments and all different settings. One thing that we noted really early on is that these press conferences that, information would be embargoed and sent to journalists, for example, those journalists might send it on to public health ahead of time. We'd all kind of get ready, and then a press conference would happen. The media would then be able to put out articles right away, and we would be able to implement. But pharmacies were actually the business from the very beginning of the pandemic, the healthcare business that always stayed open, were available, kind of all hours, were just a phone call away. So even when we just got down to grocery stores, it was grocery stores and pharmacies that were open. When these press conferences happen, they're during working hours. So the pharmacists themselves couldn't watch them. They're unaware that they're happening. They don't have it streaming somewhere. Immediately, as soon as the press conference happens, national, provincial, whatever level, what ends up happening is the public starts calling the pharmacy, and the pharmacy is being asked questions they can't answer, and the public ends up educating the pharmacist. So you get a staff member immediately pulling out a phone, trying to figure out what's been talked about, maybe social media, maybe the articles aren't posted yet. The official policy that might actually implement a change or allow a change or give rationale for a change may not actually follow for a few days. And so pharmacists scramble to try and figure out how to explain this, because they're the one person that the public can access. And then they also have these other things that they've had to respond. This has happened over and over and over again. So immediately have to hire on extra staff to manage the increase in call volume, calling the phone company to have additional phone lines installed. The phones often typically stop working because they're getting 300, 400, or 500 calls a day. So what they actually start doing is shutting down their phones and using their own personal cell phones to call patients to do their regular daily work. And then the other thing is they're often the face of healthcare. So they may be the place where patients or the public goes to express dissatisfaction or unhappiness with some sort of a policy. And this cycle has repeated, as we've seen, over and over. So this isn't a one-time thing. It's when the vaccines are first announced and the first priority groups are announced and the next priority group is announced, or there's a change in side effect, or there's some new evolving risk. Over and over, this keeps happening. And so it's been interesting to watch that frontline experience. So what we learned is that we need to anticipate that, and we need to find a way to get frontline accessible healthcare providers to a place where they can see what's coming and they feel comfortable educating the public, but also where maybe we create tools for them, for example, where they can be educating the public and learning at the same time. So they need to be things that are easy to understand, that maybe highlight uncertainty, maybe for the healthcare provider, so they're anticipating the change that's coming and possible areas of change. So how do we communicate so it isn't just change and conflict? So here's an example of one that we created early on when we realized, and this is working with a lot of vaccinators, people just struggled to make sense of, if I mix and match, is it okay? And what does mixing and matching look like? And if you recall, these were when the policies of AstraZeneca as a first dose, we need a second dose, that's an mRNA, came out at the same time that Moderna and Pfizer were being considered to be interchangeable where needed. And people were very confused. So working with frontline vaccinators, we were creating a document like this that helped the pharmacists to show, but also reminded the pharmacists and the public health vaccinators and others that there were many ways to get to fully vaccinated, but also acknowledging some uncertainty. So you'll notice at the bottom, we tested this with people and ended up adding in a message, a note on travel/variants. We're not sure if proof of vaccination will be needed to travel. Many countries are mixing and matching COVID-19 vaccines. It's important to get a second dose of any COVID-19 vaccine. No matter when you get dose 2, you will have better, longer lasting protection. 2 doses will protect you better from variants. Because what people were saying is, I don't know how to make the decision because I want to travel and I don't know how it's going to impact that. I don't know how it's going to impact variants. So testing helped us make sense of that. Here's another one that we produced around that time. I got AstraZeneca for my first dose. Which vaccine is best for my second? And interestingly, we needed to create a 6-page document because what we learned is there's a number of people who play a very special role in their peer group or in their family, where a 1-pager might work for someone, maybe a healthcare provider can show this to a patient to make a real-time decision. Or, many people can use a 1-pager, but there's often people who play special roles either as a healthcare provider or as kind of the knower, the person who holds knowledge in a peer group, where they need to be able to help other people navigate it. So we learned we had a 1-pager, a 2-pager, and a 6-pager. Everything is fully researched, everything is fully referenced, but people need different tools. And a lot of this, which you'll kind of note throughout here, is recognizing uncertainty. So the first thing we say is getting AstraZeneca for your first dose was the right decision. It's protecting you and others from severe COVID. So we're trying to avoid decision regret there, trying to emphasize, let's not look back at the decision you made before, let's look forward. The next point is now it's most important to get a second dose of any vaccine. In other words, you can't necessarily make a wrong choice here, you just need to make a choice. Then we highlight some points, and so you'll notice under AstraZeneca, there's a third point. The risk of severe blood clotting disorder from the second dose of AstraZeneca is estimated to be 1 in 600,000. This number may change as we learn more. And we actually never really did get a good solid number on that, even months later. And then getting down to the bottom, acknowledging this can be a tough choice. If you have questions about getting your second dose, ask your healthcare provider. And on the right-hand side, we worked with a human factors engineer around visual depictions. And we saw things like this come out of the UK as well. And there's a reason images like this resonates, because people, as Anton was alluding to as well, really struggle with denominators and proportions and probabilities and just basic math literacy to a certain extent, but visual depictions can often overcome that. The key is, though, we really have to test these things and make sure they're resonating. Here's another one that we designed, and this was my graphic designer who came up with this idea based on graphic novels and younger people who often engage with graphic novels. And it was just trying to hit on some of the main points. We've actually used this a lot in a whole bunch of different audiences to explain the process of how the vaccine works. So the mRNA is injected, it cannot change your DNA, et cetera, et cetera. But one thing that was really interesting about this is that we often never talk about what happens to the vaccine after it's injected. And that, in some cases, is the most important thing, because the vaccine mis and disinformation often focuses on long-term side effects. The implication being that potentially the vaccine is in your body forever. Once it's in your body, it's always there. And so what we found when we were testing this with people is the message, the mRNA then dissolves, actually was the most important or most useful. It was a bit of a side thing. We threw it in after. But that's actually what most people really wanted to know. So sometimes the visual depictions even helped us understand people's concerns and issues a bit better. Here's one we just released the other day, maybe late last week, trying to explain medical exemptions to people. And we work with a lot of specialists. So I often communicate with an immunologist who runs a high-risk vaccine clinic for people with allergies, hematology, emergency medicine, family medicine, pharmacy, but also science communicators who are really active online, getting a lot of direct messages from people uncertain. And so we collected these kinds of questions, all the reasons people think they might need an exemption, and tried to convey the information that's there. Why, this is not an exemption. Why is it not an exemption? And actually who the audience ends up being for something like that are largely employers who are now for the first time having to navigate policies they maybe don't understand. And so trying to break it down in a way that's simple. So when we first tested this, some of the feedback that we got, not this particular draft, but we were talking to people about why they didn't qualify. And one of the messages we said, how did this make you feel? Someone said bullied. So we realized the language had been strong and saying, like these exemptions can't happen. But when we backed it off and said, okay, here's the rationale for why this group is saying it's recommended. This group recommends it for the following reasons. And that seemed to temper that a little bit. So that neutral language became pretty useful. We also had to acknowledge uncertainty. As Anton talked about, uncertainty is a hard thing to navigate. So, do I get an exemption if I'm terrified of needles? And having to bring it back to the idea, if you're terrified of needles, a COVID infection may also be really hard to navigate. Previous infection, this is probably going to be our next big area of uncertainty to navigate. Natural immunity, as people call it, illness-induced immunity. There's hard, strict policies right now that people who have been previously infected must get vaccinated for the mandates, but there's a lot of conversation about the value, the strength, the duration of natural immunity. So, this is something we need to be careful about in our language moving forward. And then, of course, there's depictions like this that we're seeing come up. So this is one that we've made with Ontario data, just comparing the rates of vaccination or the rates of hospitalization in people who are vaccinated. And where this has come in really handy for us is actually emphasizing the green, and I'm talking about this, highlighting the green, saying that green person, fully vaccinated hospital is incredibly important. We want to know who they are. That green person is probably largely the ones who are getting third doses right now, and trying to explain some of this information to the public. But again, it's very challenging. So we really employ an iterative design process. We're often targeting a reading level of grade 8 to 10 or lower. We're assuming healthcare providers and patients are using the same tool. So we're giving healthcare providers patient talking points in language patients can also understand. When we're rapidly user testing, we're asking things like, what do you think this document's trying to tell you? How did this make you feel? How did this impact your decision? How do you feel about your decision after having seen this tool? What more would you like to know? What do you think? Who do you think made this document, and who would you share this document with? And we don't take feedback personally. We keep a diverse team, but also that helps us get diverse feedback. And that's where we get some of the best insights, but we can never take it personally. It's a big lesson. In terms of balancing tone, we also try to stay non-judgmental, somewhat science neutral, and target the general population. So we might create tools that target people who are sharing anti-vaccine information, but we're generally talking to the general population so that they have some background information where they can perhaps engage with family and friends who are anti-COVID vaccine at least. So I just want to highlight stories. Stories are pretty important, and vivid stories in particular. Now, you may have seen some of the posts by Dr. Markland. He's an ICU doc in Edmonton, and there's others like him. And so I've made an effort to be watching and collecting these stories, because I think one of the things we're seeing in the pandemic is healthcare providers bear witness to pretty traumatic experiences, and healthcare providers don't tend to share. And so we see a lot of stories about vaccine side effects, stories about horrible experiences, maybe false or not true at all with the vaccine as well. But we don't always see the stories of what it's like to live through COVID. And so, there's a very impactful story here, for example, that I've shared a number of times now around a single mother of 3 girls who between the school closures and night shifts hadn't found the time to get 1 shot, let alone 2, made her daughter's lunch that day. They were on the kitchen table. Her eldest called 911 when she slumped over the sink and couldn't get up. That's where the paramedics told me they found her with one of her children trying to give her a glass of water. She was so ashen, they didn't think they would get her to the hospital in time. They went with the lights and the sirens. And it continues on, this story, it's vivid. You can imagine that you're there. You can imagine witnessing it. He talks about how they're having a hard time getting her back, and it ends with this message after they're realizing they're probably not going to be able to save her. I write a note in her chart. I try not to make eye contact with the paramedics who brought her in desperate fear that they will tell me more personal details of this young woman, that they will make her real. Of course I flinch. Where are her children? Grandma has them. I reflexively clench my jaw, knowing that her children are sick. Was grandma vaccinated? Now, if you talk to people working in ICU, this is actually a reasonably common experience where there's some, both parents are coming in, there's no one to care for the children. But as we're talking with the public, they're not seeing stories like this. Here's a very different one from a physician in Vancouver, Dr. McLeod. Two guys come into an ER, one has COVID, he's sicker than he thought it would make him, crashes pretty quickly. Docs and nurses do everything to help him. He needs ICU, wasn't vaccinated. Not a hardcore anti-vaxxer, just didn't really think he'd need it. COVID, not so bad. Other guy has belly pain, it's been a month, can't find a GP, waiting for a scan, a walk-in clinic ordered. Gets a CT in ER, and it's pancreatic cancer. Docs and nurses explain it's early, they can still treat this. He needs a big surgery, but we have to delay. The ICU is full, and after the surgery, he's going to need some time there. But hey, he's not as critical as the person who had the respiratory collapse with COVID. We have to triage. It's just that the guy with COVID could have really helped the guy with cancer big time. And this is getting at something that Anton talked about, which is collectivism versus the individual. And I'm going to come back to that in a minute, but I also want to highlight this, and you may have seen this in social media. This is from an LA Times op-ed that was then turned into these Instagram-like images that could be shared on Twitter or Facebook or Instagram. And it tells from the perspective of a respiratory therapist, the progression of COVID, highlighting the point at which, if you're vaccinated, it wouldn't go past this, but then just describing in very, very vivid detail, so vivid stories, what it feels like to go through this horrible experience. And again, this is not something that we're necessarily seeing. So some of the things that we have to consider in our messaging is, are we talking about short-term benefits or long-term benefits, short-term risks or long-term risks? The public is focused on long-term risks of the vaccine and short-term risks of the virus, whereas in public health and healthcare, we're the other way around. We're really worried about short-term risks of the vaccine, which we know can happen, and long-term risks of the virus. Also, positive and negative framing. So some people respond to negative stories like what we heard there, where it's putting the fear back on the virus, not the vaccine, in a style very similar to people who are anti-vaccine. But also some people respond a bit better to, what's the future? When do we return to normal? What does a return to normal? So kids coming up in vaccines, positive return to sports, positive return to birthday parties, positive return to sleepovers might be more impactful. And finally, as we've already talked about, a lot of people respond to the idea of protecting community, but not everybody does. And we're at the point with the adult vaccine rollout that probably the people who want to protect the community have already been vaccinated. And those who are left are probably more motivated by self and stories about how they themselves. So vivid stories about their role as parents, their role in caring for their children, being around to care for their children. All of these things probably need to focus more on self. So in conclusion for me, messages today are impacted by messages from yesterday, and messages today will impact messages tomorrow. There are unintended impacts of our messages we have to be really careful about. So user testing is helpful. It can flag unexpected issues, and really using vivid stories and vivid visual images can help convey risk. And we need to make sure that we target that style and message to the motivation and to the audience. Thank you.
Thank you so much, Kelly. So much information, and it's such a short period of time. Thank you for answering the question, what happens to the vaccine? Serendipitously, I was thinking about that just yesterday, and I thought, I'm going to have to ask someone smarter than me to answer that question, because I could make up an answer, but it was better to have the real one. And I so wish that every government in this country did that rapid user testing of their websites and brochures and all the rest that you spoke of, because it would go a long way to improve that information out. So we have a couple of questions already. I encourage everybody who has been listening in, if you have questions, post them in the Q&A function at the bottom of your screen. But the first question is from Jeremiah, and it's for Anton. He writes, you mentioned framing vaccines as a way to, quote, get the government off their backs for individualist mindset people. How is that compatible with the increasing government adoption of vaccine passports, which are perhaps the biggest pressure to get vaccinated that these people have experienced?
Yeah, that's a great question. I think it's about maintaining consistency through the whole process. So the people with the individual mindsets who are thinking about their autonomy and their freedom are probably also the people who are thinking that it's unfair to put the burden of things on people who work in bars and that kind of thing. And if we can frame the fact that a vaccine passport kind of lifts that responsibility from those people, you're carrying a thing that shows this, right? And it's a very simple and easy way for those people just to check it off a list. Then I think that will resonate with those types of people. And also how this gets rolled out. I mean, if there's a really easy to use app that's provided, that if it can be easy as carrying around your driver's license, then that's one thing. If we have to, in the case of me, I had an AstraZeneca shot and a Moderna shot, I have to carry 2 bits of evidence that show that I got both shots, right? So that makes it complicated. If we can simplify that process, that will help.
Great, thanks, Anton. I think the second question is for you, Kelly. Have you tried A/B testing on social media? And if so, would you be able to share some results from that?
This is such a great question. So we've recently had some funding, just starting the projects that we're receiving the funding for. And this is one of the components of that, because it's allowed us to engage with communication scholars and individuals who are watching social media data. So one of the things that I'm going to redirect this question a little bit because no, we haven't done what you're talking about. We will be doing what you're talking about. But there are some interesting insights that we've gained from some of our colleagues in other provinces, for example, around the fact that if we look at social media data, I'm from Alberta originally. I'm in Ontario right now, but I come from a small town with a very low 2-dose vaccination rate. Last I checked, it was about 30% 2-dose. It's a rural Alberta community, very different from other places, very active social media postings, very divided. And we see that from the social media data. Twitter is the place we see it the most because Twitter allows researchers to essentially scrape the data and you can be analyzed, whereas Facebook and Instagram don't allow the same kind of access. So you can't have that same high level. But one of the things that they have noted is that very, very polarized. Obviously, there's groups who are very pro-vaccine, groups who are very anti-vaccine, not a lot of overlap, but there are still individuals who bridge those two sides. And so one of the keys sometimes is trying to find the bridgers who go between both sides and can share information that isn't alienating to either side, right? That answers one side's questions or resonates with one side while also penetrating the other side. And so that's going to be some of our questions looking forward is, I have colleagues who are doing exactly what you're talking about. It's not A/B testing in quite the same way. It's like a factorial design, varying things like long-term, short-term, positive, negative, et cetera, working through it with some very specific, a lot of more psychological rigor, tools, et cetera. But I think it's a very good question about just on social media, even in metrics, when you release something one way or the other, where does it go? Which cloud does it get sucked up into? And does it spend any time bridging the two sides?
Excellent. So as we wait for our participants to perhaps pose the next question, I'll pose one of my own. I always thought that that early debate, and it really was, we'll call it the debate about masks, and that in a large part, the real point of that discussion was missed, because in the beginning, we were talking about wearing masks to protect ourselves. And we knew, because there was a shortage of the proper PEP for healthcare workers, we didn't want the general public wearing those, and any kind of mask they could wear wouldn't protect themselves and give them that false sense of security. When the narrative changed, we realized, oh, well, the reason why a surgeon wears a mask is to protect the patient. Oh, okay, we should be protecting other people from us. And I really feel that that was lost. But I guess my question is, does it make any difference? Because it was a shift. Is that too nuanced for the general public to really dig into and be able to discern why there was a change in policy? Maybe Anton first, and then Kelly, if you have some thoughts.
Yeah, I think so. My recollection of how that first was rolling out was the messages were things like, there is no evidence to show that masks will protect you. So that is kind of an absolute statement, right? There's nothing out there showing that this is. The messaging, I think, should have acknowledged it's always okay to acknowledge the uncertainty, right? And to say, look, we don't know at this time whether masks will be that effective in helping you. What we do know is we need them for healthcare workers, right? That's the priority at this point. We're going to continue to look into this, and when we find new information that changes this, we'll let you know so that you can protect yourself. It's a different way of framing it. If you start off at the bat saying don't do this, then people are going to say, okay, I'm not going to do this. And then if you shift gears and say, okay, do it now, that's confusing. If you say, look, it's kind of like the messaging you get, in nuclear communities, right? They have messaging like, it's get inside, stay tuned, right? So that's the kind of situation you're in. Wait until we have more information for you, and then you can act. And so I think that's how that should have been handled.
Great, Kelly. Any other thoughts?
Yeah, I think I agree with everything Anton just said. I think there was that shift from masks to protect yourself to masks to protect others. But now we're going through another shift, which is masks to protect you from aerosols. And that's where we get into N95s and the KN95s or the FN95s. What's a good enough 95 style mask? And again, getting into questions about adequate PPE access in some of these facilities like hospitals or pharmacies, interestingly, had a really hard time early on in the pandemic accessing any PPE because they weren't originally considered within the institutions that might need to be protected as well, which also sowed its own, like who gets what? Is it fair when there are limited resources? How do we concentrate them? This goes back to, I think, my comment about conflict. This was a really challenging time of conflict that I suspect is very much haunting us right now. And the ongoing conflict around aerosols is probably also hurting us now, but into the future. So one thing that I thought helped is when we started shifting into the idea of the precautionary principle. And, if we don't know, it's better to err on the side of caution. Whereas when we first started the pandemic and we were still in like pre-pandemic mindset, it was like, well, why would we do anything if there's no evidence, is the way we used to think of it. Then along came a global virus. And we had to start shifting into, okay, but if we don't know, maybe we should be on the safe side and just say, maybe this works, let's adopt it. That's very nuanced for the public. Frankly, as a frontline healthcare provider, it was nuanced for me as well. And it took a long time to make sense of this. I think that's one place where social media helps and hurts us, though, because this is an area where some very high profile people are expressing conflict very publicly. And there's a lot of lay people who are not accustomed to watching that play out. And I think they're watching it. It's exciting. It's interesting, but they struggle to make sense of it. And I sometimes think that that's amplifying the conflict in a way that's going to amplify the challenges we're going to face in the future.
That's great, Kelly. So our next question up is from Rachel Goodland. I have encountered folks who believe vaccine hesitancy is about the lack of intelligence or ignorance, and have a lot of anger towards those who are vaccine hesitant. How can I work with these folks to see the complexity and the cultural factors that may contribute to vaccine questions or hesitancies? Any resources that she could share?
Maybe I'll answer this one first. So yes, I agree completely. Having grown up in a community as well that has significant vaccine hesitancy or opposition at this point, it's a real challenge. I often find myself just every chance when I talk about this, almost every chance I get to say, I will not call people anti-vaxxers. You won't hear me call them anti-vaxxers. People who are not choosing the vaccine are not bad people. Like reiterating that message that these are people who have often legitimate concerns or are exposed to very dangerous misinformation or disinformation, more likely. So I very much emphasize that. And I don't know about resources. There's a really nice, I almost included it, but I don't have it, a graphic that shows the spectrum of vaccine hesitancy, where there's people who will refuse all, people who will accept some when they're unsure, or refuse some when they're unsure, people who will delay when they're unsure, but they'll eventually get it, people who will accept even though they're unsure. So it's also saying people who are refusing and delaying are probably the same as people who accepted but were unsure. They just are able to make different decisions in the context of uncertainty. And then people who will take everybody or any vaccine. And there is some concern right now that the vaccine evangelists may also do some damage. You know, they'll take anything, the ones with kids, not waiting for information on risk. I will take it. I will take it the second it comes out. You know, provided the data is sound, I probably feel like that, but making sure that we're not conveying a message that sounds like, it doesn't matter, you know, I will always take it. So reflecting a spectrum, I think is pretty important here. So I think it's a great comment.
Thanks, Kelly. And I just posted in the chat a link to the spectrum that you were speaking about. Anton.
Yeah, I think also in a lot of those cases, it's not that people are unreceptive to that information. They just don't know. They're confused, and in some cases, a little scared of what they don't know. So in that situation, there's a vacuum, and the vacuum is being filled by all of the other stuff that's out there that is misinformation or even disinformation, where people are actively trying to confuse people. So if you're engaged in a personal conversation with someone, a good way to deal with that is just to ask them questions about why they're feeling a certain way. And through that discourse, people will often talk themselves out of their position as it's being revealed to them through those questions. And it's also important to keep in mind too that there's about 5% of the population that have immovable positions, and you have to recognize that and just don't waste your time and effort on that, because your time can be better spent with other people.
Great, thanks, Anton. So our next question is, so the University of Waterloo's Pharmacy 5 in 5 resources have been great to use on social media and to email patients while I, or the questioner, was immunizing in a pharmacy. One of the biggest challenges, other than staying on top of changing guidelines, is trying to get the general public to understand that guidelines will change. Science is changing, and it's a new virus that we're all learning to live with. What are some strategies we can use?
I think this is a great question, because I think there's two levels to this. One is that I think we've seen in the pandemic that there's groups that are communicating directly to the public that have not traditionally communicated directly to the public in the past. And I'm not sure that at even that level, when the public is hearing from groups they've never heard from before at quite the level that they are, that the message, even starting from there, things will come out with certainty. The message will sound certain, but often it's very uncertain. It's the best decision we can make at this time with the limited information that we've got. That message is often lost. And I'm not sure it's the people delivering the message or more that how it gets filtered and to reach the individual. But I think that might be one of the biggest challenges we've discovered or experienced in this pandemic, is people not accustomed to talking to the public are now doing it for the first time and learning as they go. So I have a lot of confidence we're going to emerge from the pandemic as pandemic veterans, and we're all going to be so much better at all this stuff by the time this is all done, because we'll have made all the mistakes. But I think what this is asking about is on an individual level, communicating on an individual level, one-to-one. One of the things I've learned is not necessarily to be too confident in what a policy is right now, and you know, conveying that at this moment, right now, based on what we know, this is what we're doing. So where this is going to come up really importantly is in kids' vaccines, which is the next big hurdle we expect to hit in the next month. So, you know, probably avoiding messages early on. We talk about the vaccines being safe and effective. There could be myocarditis with kids. There could be something else. We don't expect it. Here's why we don't expect it. the bridging trials, 2,000 people, it's going to get people going. But there's a lot of science and procedure that have gone into this, to assessing this. And the public doesn't necessarily understand that. So kind of, it's a very rambling answer, I guess, but anticipating where people are going to be at without too much confidence, acknowledging their concerns, acknowledging their worries, and telling them why at this moment in time, this does seem like the best decision that we can make. So I will, I guess, conclude this by, for me, a lot of what I'm doing is shifting back from concerns or fears about the vaccine being experimental to communicating about the virus being experimental. This is a new and novel virus. We know very little about it. We don't know the long-term implications. We need research about the virus to know what's going to happen in the future. We have lots of viruses in our lives who actually hang around for life. And we've got HPV, which causes cervical cancer, hepatitis viruses, which cause liver cancer, cold sores and all sorts of things stay with us for life, and reorienting them to the fact that our responses right now are in response to a novel virus we know almost nothing about. And isn't that worrying? Isn't that concerning? So I don't know if that helps you, but I found in more recent months, my shift has been to focusing on the risk of the virus as being pretty key.
Great. And then I think our last question for the afternoon is, how can this concept of risk communication be embedded into vaccination conversations if we look past the pandemic and into vaccination catch-up conversations? Anton, did you want to perhaps start with that? You're on mute.
Sorry about that. Yeah, I think it's, being mindful of all of the principles we've been talking about today, and keeping in mind that even though we'll be past the pandemic part of things, there will always be situations where people continue to be a little confused about things, and we can address some of the issues of uncertainty. For example, people are talking about there wasn't enough testing and that kind of thing. Well, we've now had a global test, right? I mean, millions upon millions of people are getting the vaccination. So now we have new information that tells us that. And we can, people can draw comfort from that, knowing what the outcomes are from there. So it's, keeping on top of how that's changing as well. So that, we can now change from talking too much about uncertainty to now how things are working out, and how we are starting to understand this a little better going forward.
Thanks, Anton. Kelly?
Yeah, I think one thing that we need to do too is, and I've done this before, almost demanding or expecting a higher level of communication competency from groups who for the first time now have been communicating with the public, and really doing an admirable job when they had no experience necessarily doing this or very little support. But for example, when people are communicating to the public, making sure that they have strong communication supports, that resources and funding is put towards communication, that you have competent communication professionals. So you aren't putting it entirely on healthcare workers or scientists whose expertise is actually not communication at all. Thank goodness, because they might know everything there is to know about antibodies and T cells. But now expecting them to also be communication professionals is too much. And I really see a lack of clear roles for communication professionals in terms of, we know what they could do, but they aren't necessarily invited to work in those spaces or given roles in those spaces. And so I think definitely moving forward, I would like to see a lot more opportunity and funding for expert risk communicators and communication specialists at all levels of public health communication. I think there's an enormous amount of value in that.
Mm-hmm.
I couldn't agree more, Kelly. And I know that post-SARS and H1N1, there were a number of programs and put into place, and training opportunities put into place that slowly, one by one, they got dropped as, we're not going to need that again. We're never going to have another global pandemic. So we are out of time this afternoon. So thank you to all of our participants for your great questions. As mentioned before, the recording of today's webinar, as well as Kelly's presentation, will be posted to CPHA's YouTube channel. And everyone who registered for the webinar will receive a link to that as soon as it becomes available. I want to thank once again Anton Holland and Kelly Grinrod for their expertise and their willingness to share their valuable time with us this afternoon. I think it's been a great session. And I want to thank again GSK for their support of CPHA's annual conference and today's webinar. So take care of yourselves and please be kind to each other. Have a good day.
Thank you.